Hello, people. Today I would like to talk about hematogenous osteomyelitis and basically osteomyelitis in general. This is osteomyelitis is an infection of bone, and it is often said hematogenous because many forms of osteomyelitis, especially in children, are mostly the bone is mostly infected via the bloodstream, and the bloodstream plays a big role in infection. So hematogenous osteomyelitis, we can separate it into a few different groups of patients. So we have young children. We can talk about neonates and infancy, then older children, and then adults. But basically, the disease is different in children in comparison to osteomyelitis in adult patients. So first of all, we will see hematogenous osteomyelitis of neonates, early infancy. So these first weeks and months of life and the first year of life, how does osteomyelitis happen in this population group? So basically, this hematogenous osteomyelitis is essentially a disease of childhood, especially in children that are in some way sick, malnourished, and so on. There are basically also three paths in which the bone is infected. So the first and the most important part is obviously one of the bones that is commonly a site of infection is the femur. So the femur is a bone that is commonly infected, and the lower extremities account for 2/3 of all infections. So basically, via the bloodstream, bacteria comes to the metaphysis of the bone, and because special properties of these very vascularized parts of the bone, the bacteria can lodge in there and multiply and cause osteomyelitis. So the first way in which children can get osteomyelitis is via the bloodstream. Of course, this also applies to adult patients. So the second way is post-traumatic. So I will make here. So post-trauma. Basically, if there is trauma to the skin, a fall, or some accident where we have skin trauma, and when it penetrates all the way to the bone, of course, bacteria can enter and cause bone infection. Then there is the third possibility. The third possibility is basically a continuous spread. For example, if some injection is given to the children in the buttock, and if it is given the wrong way, we can have infection here, and this infection can from this neighborhood area of the bone spread to the bone and cause osteomyelitis. So a continuous spread from a neighborhood area of cellulitis can spread to the bone and cause osteomyelitis. So basically, these are the three main ways osteomyelitis is the main pathophysiology of it infecting the bone. And the main bacteria that is causing the osteomyelitis is most of the time Staph aureus. So Staph aureus is that is infecting the bone, has special, they call it a bone skeletal tropism. So skeletal tropism. Other bacteria can also infect the bone, Pseudomonas, Proteus, E. coli, and so on. But Staph aureus is a bacteria that has shown affinity for bone, and it can easier infect bone tissue and cause osteomyelitis. So why does this hematogenous osteomyelitis happen, and why does it happen in the metaphysis of the bone? So if we see here, these are two ends of two bones and in a joint. And first of all, we have here is the diaphysis of the bone, and here is the epiphysis. Here is the growth plate, this blue part, so this would be the physis, and this part is the metaphysis, so this would be the metaphysis. So the bone metaphysis is the main site where the bacteria lodge. This is because this is a highly vascularized area, and when the arterioles come here, the blood slows down in the metaphysis, in this capillary bed, because before the blood goes into the venules. In this capillary bed, the blood slows down, and bacteria like Staph aureus that have skeletal tropism enter into the bone tissue and start an infection. An infection that starts in the metaphysis of the bone in children that are about from when they are born, about somewhere to the 18th month of age, there are vessels that connect the metaphysis with the epiphysis. So there is no barrier actually between these two parts until somewhere in the 18th month, when the communication stops to exist. The blood vessels are not longer present. But before the 18th month, there are blood vessels that connect the metaphysis with the epiphysis. And you can imagine that bacteria now can spread to the epiphysis. Also, they can infect further to the diaphysis, so an further intraosseous infection. Also, the bacteria can go into the soft tissues and cause cellulitis and myositis. Also, bacteria can cause abscesses in the soft tissue or a subperiosteal abscess. So a subperiosteal abscess basically lifts off the periosteum, and the bacteria colonize under the periosteum, between the periosteum and the bone, and cause a subperiosteal abscess formation. There is also a possibility to easily infect the joint space, causing septic arthritis. And also, if septic arthritis happens, it is easy in these children for septic arthritis to spread to the epiphysis and then further to infect the bone. So basically, these infants, because their immune system is not formed, because they are, especially if they have an underlying condition, for example, if they're malnourished, their immune system isn't really ready to fight a pathogen like this, and a simple trauma where Staph aureus enters the bloodstream can enable it to go to the good, very well vascularized parts of the bone, like the metaphysis of long bones, like the femur and the tibia, and to start an infection there that can cause many different problems later. So now this is the etiology and the basic pathophysiology of this disease, but there are also some problems in treating this because it can be hard to detect, especially young children. They can't tell the doctor where is the problem. So when it comes to the symptoms, classical symptoms in these children are absent. What is important is to notice an unwillingness to move. So there so the children are unwilling to move the extremity. Also local swelling, local rise in temperature are some signs, and in younger children also the child fails to drive. So it is not developing like it should, but when we notice this, then the osteomyelitis is already too far gone. So the important thing is to notice that the child has a problem, that it is not willing to move the extremity, and that there is maybe a problem, or if we move the extremity there is a reaction. So then when we suspect that there is maybe an acute osteomyelitis present, then we need to do diagnostics. Blood works is the first thing we do. So with CRP, sedimentation, and blood analysis, in osteomyelitis, in most of the cases, we have a rise in these parameters, and then we can do x-rays of a suspected site. X-rays in acute early osteomyelitis are only good to rule out other conditions that could cause the problem. Also, blood culture can be taken, but they are positive in only 30 to 50% of the cases. So basically only bone paracentesis, and it is hard to do it in little children, can give you a better result. So maybe 70% of positive results. And one analysis that is also promising is MRI. So MRI in small children, basically the problem is because they move, they need to be anesthetized, but we can do a whole body MRI because of the small size of the body. So if we suspect and have a high suspicion of osteomyelitis and diagnose it, then of course we need to give rapidly a therapy. So first of all, we need to do splinting of the affected extremity, and twice or more times a day we need to check the extremity. Then also antibiotics, mostly in the first days and weeks, are given intravenously, especially if we don't have culture antibiotics that are good against resistant staph aureus. The leg is regularly checked and examined twice or more times a day. And after 48 hours, we basically need to have some kind of response clinically. If there isn't any response, we need to see what is not working. And also, if we ultrasound can be, we can use ultrasound to examine the soft tissues and the periosteum. We can do more diagnostics. And if we see something that abscess collections forming or something that needs decompression, maybe we would do a decompression, a drainage via the simplest route and continue this therapy. If the antibiotics are given in the first days of the infection, there is a high possibility for the treatment to be effective and for the child not to have lasting problems of the infection. So basically, if there is no treatment with antibiotics, the infection can damage the growth plate, so the physis, that will result in growth abnormalities of the bone, in deformations. Also, damage to the joint, if there is infection, can cause severe arthrosis of the joint and destruction of the cartilage. And also, if the infection proceeds into the bone, it can cause later, if it is not settled in 6 months, it is then termed chronic osteomyelitis, and then it is a chronic problem that is very hard to solve. So it can also, a complication can be abscess formation. So the subperiosteal abscess formation can happen. So a subperiosteal abscess happens because in children, the periost has two parts, a upper fibrous part, so an upper fibrous part, and an inner very vascular part. And the upper fibrous part can be easily lifted off, and the infection spreads to this vascularized part and starts forming pus, and a subperiosteal abscess happens. It can continue in this subperiosteal space, but only to the perichondrium, because here are tight junctions. It can continue further this way. The subperiosteal abscess can also break into the soft tissue, spread into the soft tissue, cause cellitis, and also it can break outside with a sinus, causing pus drainage. But these are cases, hard cases with complications. And basically, these abscesses, so subperiosteal abscesses and other abscesses present in the bone, abscesses that are about 3 millimeters will definitely resolve with without surgery, with antibiotics. But soft tissue collections that are more than 2 centimeters always require some surgery and don't resolve without surgery. So these resolve without surgery, and these always require surgery, and they will not go away only with antibiotics. If the infection of the bone becomes a chronic problem, the bone can change, and some changes can happen, and these changes are easily visible on x-rays. So first of all, we have an infection. So this infection Then if it is not treated right, this focus of infected bone, if it is not treated right, then the bone there starts to die, and there are pieces of necrotic bone present there. These pieces of necrotic bone are called the sequestrum. So the sequestrum, and around the sequestrum there is new bone forming. So the body is trying to protect itself, and it is forming new bone around this dead bone, and this new bone is called the involucrum. This is how it evolves, and if the chronicity, if it is not treated, eventually the infection will break out of the dead part, and it will break out the new forming bone. It will cause infection of the soft tissues, and later, so in months and years, if it is uncontrolled, it will drain via a canal outside. So it will form a sinus, and this sinus, if it lasts for years and years, so we are talking about a period of 5-10 years, it can become a carcinoma. So the tissue can change into some kind of skin carcinoma. So this is osteomyelitis in simple terms. The problem here with children is obviously getting the early diagnosis, getting the pathogen and the antibiogram early. If we can do bone paracentesis, which is paracentesis, which was the best method, and then giving the appropriate therapy as fast as possible to stop complications from developing, and eventually completely getting rid of the bone infection. Thank you.